So thank you guys for sitting to let me talk to you. My name is Ashley. I'm doing this for my instructor methodology class. I'm going to talk to you guys about needle decompression. So the objectives, why we do it, what the signs we look for, where we decompress at, the equipment that we're going to need, causes and some risk factors, and then we're going to let you guys, I'm going to show you, demonstrate on the mannequin, and then let you guys come up here and go at it, stabbing the mannequin with needles. So for your lungs and your chest, when you take a deep breath, they expand. And then when they do that, it creates a negative pressure inside the pleural space there in your cavity. What happens is if you get some type of hole in there in that pleural cavity, like in your lung or just in the cavity itself, it lets more air in. It cancels out that negative air pressure. And in a sense, it ends up collapsing that lung on that side wherever the hole is. So the biggest thing, you want to be able to keep the negative pressure in there. And that's what helps keep your lungs expand whenever you take a deep breath, and then go back to a normal size whenever you exhale. So a pneumo, it's a collection of free air in that chest cavity that causes the lung to collapse. It can occur on its own. It can occur because of some type of underlying lung disease or some type of trauma. If it collapses on its own, it's what they call a spontaneous pneumo. If it collapses usually under trauma, it becomes more of a tension pneumo if it's not treated quickly. Like I said, it can also occur because of some underlying diseases like COPD, pneumonia, cystic fibrosis are usually the biggest ones as far as a type of disease that will cause them to collapse. With the pneumo, if it keeps getting worse, either from an injury or a lung disease, it needs to be treated immediately, or it can cause someone to die. So with the tension pneumo, what it does is it compresses the structures in the chest, which includes all the vessels that return blood back to the heart. You don't return blood back to the heart can't pump, you die. Very bad. We need to treat it. So when it accumulates and pressure builds up, what it does is it pushes that mediastinum over to the unaffected side. So if your injury is on the left side, it pushes it all over towards the right. It can collapse the superior and inferior vena cava, so you're not going to get any of that blood return. It also can displace the heart and the trachea. You're putting pressure on all that. And then, like I said, it's going to decrease your cardiac output. You don't get no output out. You're not going to get no blood flow back in. Very bad day. So signs ranging from very minor to more severe. A lot of times it's onset with chest pain. It's usually pretty severe. Can get a tightness feeling in the chest, some shortness of breath, rapid heart rate, rapid breathing, fatigue, cough. You'll have absent breath sounds on the side that is collapsed. You'll have some subacute emphysema. You can get some anxiety just because of the feeling of not being able to breathe. You'll have some JVD. Worst cases, you'll start to become a little cyanotic. And then you can also have some tracheal deviation if it's that severe as well. My husband has several. He's had 3 confirmed. His have all at least been low enough to where they haven't had to put chest tubes in. But his symptoms is he gets chest pain, he gets shortness of breath, and just that feeling of he just can't breathe. And it just kind of gets a little worse. He's had, I think, probably a lot more than that they just haven't confirmed. But usually a chest x-ray can confirm it. If it's a big one, if it's smaller, they'll need a chest CT to do it. And that's usually how they actually confirm he is with chest CTs. But usually, if they just look at it on an x-ray, a lot of times if it's big enough, if it's over roughly 10% of its collapse, they can see it on a chest x-ray. And then, depending on how big it is how they'll want to treat. So your causes with the spontaneous pneumos, which is what my husband has, they call them blebs, which is basically it's like a small cyst that sits on the outside of the lung. It ruptures, causes a small hole. So those is what you have with your spontaneous pneumos, and usually those are a lot more prevalent in men, tall, skinny. I do know, like, whenever we started dealing with that with my husband, the surgeon told us that, like, he's described, like, men like Abraham Lincoln size, really tall, really skinny, are more prone to have that. They don't really know why. It's more prone in those type of men with those body builds. But other ways is some type of injury, like a gunshot wound, a stabbing, or like if you get hit, fracture a rib, like a car wreck or anything. Also, for me, type of like surgical procedures that's in the chest cavity, like when you have people that have like open heart surgery or stuff like that, or like fix a valve, if they go in, they could possibly nick the lung, cause a pneumo that way. And then, like I said earlier, with the lung diseases like your COPD, your pneumonia, and your cystic fibrosis patients. So risk factors, like we just talked about, more common in men than women. Smoking, even without like the emphysema, is shown, like people who have them reoccurringly are usually smokers. Between 20 and 40 for more of like your spontaneous pneumos is kind of more the age frame there. Genetics. If your mom or dad has spontaneous pneumos, or if you do, kind of seems to be passed along. Again, no lung diseases. People who are on ventilators, if their settings aren't right, you get too much pressure build up, you can pop a lung that way. Or if they spontaneously have pneumos before, they're more likely to have more. Usually within like a year to 2 years, they'll see it. We've had one about every year for about 3 years that we, like I said, was confirmed. It was about every year we were having another one. Pretty sure there'd been more before that they just kind of wrote off as he was young and had chest pain and didn't want to really do anything. But
anything that precipitates that?
One time he was at work, like just bent over to pick up a box and actually pick it up. Felt like a pop in his chest, started having severe chest pain, shortness of breath. There was another time he was just outside playing with Alex, just kind of running around in the yard. It happened. And then the other one, he was just driving down the road and just felt that pop again. So nothing has been, for him anyway, has been anything, same thing or anything like that. And every time they end up having to do a CT. The only reason they got it the first time is because I told the doctor that there was something wrong and he just wasn't doing enough to figure it out, because his EKG had looked fine. He even told me his chest x-ray looked good, and he just did the CT just to basically shut me up. And then he come back in and he just kind of threw his hands up and he was like, his lungs collapsed. He's like, and I'll go ahead and tell you, I did see a little thing on the chest x-ray, but I just thought it was something on the film. So it's always good to push when you know your body, you know something's wrong. And that was the only way I did, because his blood pressure usually kind of ran a little lower and it was more elevated, and I could tell he was in distress. And for him to actually call me and say, hey, can you take me to the ER? Like, I knew something was wrong. So the equipment that you'll need for this, obviously you're gonna need like your PPE stuff. So you're gonna need gloves, safety glasses. You will need a syringe with about 5 mLs of fluid left in it, not a whole thing. For whenever you do the procedure, it's gonna help you know that you're actually in the cavity there, because you'll see some air bubbles come back up in the syringe, so you'll know you're in the right spot there. More of a commercial device for your decompressions. It's the big 14 gauge needle. These are used for your adult patients that are over the age of 15. Also, if you just have like a standard 14, if you don't have these, it can be used. Other size needles, a 18, anyone from 1 to 14. You can use an 18 gauge needle on those. For the 20 for 1 month to 1 year, and a 22 for a neonate, so anything under 1 month. Bad day if you gotta decompress a kid under 1 month. Probably gonna pick up and go to the hospital, because I don't know anybody who wants to stick a needle in a kid's chest. You'll need some type of flutter valve. You can use the glove of a finger. Some young men, check their wallet. If they got a condom in there, it'll work too. If you carry Asherman's, the flutter valve. You're not going to want it if it's got a hole in it, man. Another way you can do it is with a 3-way stopcock. But if you do use this, every time the patient goes to take a breath, you got to open it up, close it back when they exhale. So a little more work with this versus just using like a glove of a finger. But either way works. And we'll go over the process for that here in just a bit. Oh, I went backwards. Oh, yeah, you're also going to need a stethoscope because you got to listen to breath sounds to be able to hear. You're going to need some oxygen. It'll probably feel a little bit better for them if you give them a little bit. Usually, if they're that bad, you'll use a non-rebreather. If they're not overly bad, you maybe will get away with a nasal cannula.
So, quick question.
Yes.
I may have missed it. What is an Asherman?
I have a picture coming up I'll show you, but it's like a generic seal that goes over it. The base is round and it's sticky, kind of like the IO dressings. Mm-hmm. You put over and it's got a little valve up top, and so whenever it'll like move as it breathes out, kind of like your glove finger. Yeah. Mm-hmm. I have a picture of one coming up here in just a little bit. I'll point it out to you. So your locations. You technically have 3 different locations that are acceptable to use when you do a decompression. With our service, we just use the one, which is the mid-clavicular second intercostal space. You can all do mid-axillary or anterior axillary. You'll use the 4th or 5th intercostal space there when you go to do it. A lot of EMS services just does mid-clavicular, but there are some services that promote the mid-axillary. Also, an interesting fact, maybe it might come over to the U.S. eventually, but overseas, mostly in Europe, instead of doing decompressions, they're doing simple thoracostomies. So they are using a scalpel, cutting the skin, sticking forceps in between their rib cages, spreading them, and they're using their finger to go in. It's pretty much just like getting a chest tube put in, except you're not actually putting a chest tube in, but they are EMS services over there that are doing this. So maybe, depending on how the research and stuff goes, we got some no's over here and some yeses. It may be something in the future that we see to start to come over to the States as a practice. I'm probably sure they're going to wait for, do what? Yeah, that's the only difference. You use your finger instead of the tube. So once you use that forceps and you pop that open, you stick your finger in there. So I'm going to show you guys a video real quick. Travis. Get Travis because my video, it played earlier. It's not playing now. My video won't play. Like it played earlier whenever I did it. Yeah. It's embedded in it. I can get it. So, does anybody have any questions while I'm pulling this up?
Maybe click on the enable content.
Oh, you know what? You're right there. Probably work. Let's see. Yep. So what this is going to be? Oh no. Whoa. When we get this to play, this is what it looks like on the inside of the chest cavity once you do that decompression. So so there's your needle, your catheter, and in a second you'll start to see the lung down here, right there. Oh yeah. You'll see it come up in a minute. So you see he's in the chest cavity, so he took the needle out, so you got your catheter there. So if you watch right down here, there's your lungs starting to reinflate.
Wow.
Well, ain't that just nifty?
So this is the side of it we don't get to see normally. I do not know that. Probably a lot bigger than what they did in that chest for that needle.
You seen that movie where they get in the spaceship?
Yeah.
Magic school.
Wow. That's pretty neat.
Mm-hmm. And all the studies that they've done with them, just that catheter being in there and that lung pushing up on it should not cause that lung to recollapse. They should not puncture that as long as that you've actually taken that needle out before it gets reinflated. Big key. So I have one more that I want to show you. This one is kind of like what it looks like in the ED. They do a little bit different of a process for like their decompression. Just it's kind of like a Hickman. It looks a little bit different. I just thought it was really interesting, so you can see the difference in it. I'm not going to play this whole video. I fast forwarded to the part where they actually do it. So right here, they're actually numbing him up. And in just a second, and you'll hear him talk about it, when it zooms back up, you see the air bubbles coming up.
Mm-hmm.
That way you know you're in that thoracic cavity there.
Okay. Well, how many? So that needle that you had was 1.5.
So they make a little incision there to help their decompression thing go through. This is the part that makes me hurt when he gets ready to push this in.
Oh.
And then you watch the pressure that he has to put on to get that to go in.
Oh.
So this is the device that they use in the ER. It's simply just the same like when we would do a decompression. But that little box that you see on there, so he's going to pull the needle out. So that little box that you see right there, that tube that goes out of it hooks up to suction. So that way, if need be, no, it does not.
Tell us if you're feeling bad.
That's where if any fluid does come out, it'll collect right there, and they can measure that.
So it's like
But
a
it,
miniature hospital size.
right. So like the big chest tubes that you see in the hospital, people carry around them big old boxes. That's just a smaller version for the smaller pneumos that you get. And it just tapes down on there. Yeah. They did not pre-medicate him. Like if you watch the whole thing, he was not pre-medicated or anything. Yeah, that's all I got. Just little lidocaine to the chest. No. So anybody have any questions about it, about the process or anything like that? If not, we will practice. And Stephen, there's your Asherman.
Okay, so
Yeah.
We used to carry just the tube itself, not the actual seal. You
Yeah.
remember that?
Penrose drain.
Yeah, the Penrose drain. What they
Yeah,
put in like
so
surgical wounds and stuff to drain. That's what we
that
used to
just-
carry for flutter valves.
Yeah, that just goes over it. It's your flutter valve.
I've also heard that you
Would
can
be
use IV tubing
Mm-hmm.
in a bottle of sterile water, and you create sort of like
Like
the
a
same
suction
type of
type thing. Mm-hmm.
like it does at the hospital. You
Yep.
screw the IV tubing on and then drop it into this sterile
Mhm.
water. You just have to make sure it stays in the
Yeah.
water, so it closes that whole seal.
Yeah, there's a lot of different ways to do it. Whatever your service recommends. With that, you just got to be really careful. Watch it when you transport down, to make sure that stays where it needs to
Yeah,
be.
in the water.
Yeah. So, what we'll do, let you guys come up. You can feel on the mannequin where it needs to be. And that's why, when he was numbing it up, you seen the bubbles come up. That's why if you use a syringe, like if you have one long enough, you can use a syringe with like 5 cc's in it, and then you'll watch the air come back up in it. And then you know for sure you're in the right spot. So anybody want to come stab the mannequin? You'll come get.
What are some of the complications that you can have by sticking a needle into somebody's chest?
Well, if you don't get the right placement, and you go when you do it, go over the rib because there's a lot of vascular nerves right there. You can cause some bleeding, some additional trauma there if you don't do it in the right spot. Another reason we do it up high is because we can't tell how collapsed that lung is. So if we try to do anything a little bit lower, we run the risk of actually puncturing that lung itself. So that's why they like to keep it up high. Oh. Okay. Anybody else want to come stabbing? You got a couple landmarks there. And not that it's really a condoned way to do it, but another way to get your placement is if you take the patient's hand, not yours, the patient's hand, put it right there in that notch, and put it straight over where your pinky stops at should be your landmark. So if you've got like a bigger patient or that you're having a hard time feeling, put your thumb right there at the bottom of it, put your hand over, and like keep it to get like in a position, and yeah, and then about where your pinky is pretty much where your landmark should be. It's not the condone way, but it's another that people do use to figure it out when they're having trouble, because some people you can't feel those ribs. You have a hard time, so that way you're not guessing at it and just going in blind. It's another way to do it.
So pretty much if you have a bigger person, that would be your preferred method if you can't feel any of their landmarks.
If it's condoned by your service, yes. Like if they promote it, then sure. Or if it's your only way.
Well, sometimes you get the larger population. Like
Yeah.
You can't feel all that stuff.
Put some pressure on it when you feel.
They lay back,
Yeah.
flat, and gravity takes over.
You might have to work a little bit, but you can feel.
It's okay, work.
Yep.
Good work.
All right. There's no other questions?
How many attempts would you do?
Depends on how many your service allows you to do. If you can find your landmark, one time should do it. If you have a bigger patient trying to get through all that muscle, if it don't go through, like if you don't get that flow, it's because there's too much muscle mass to get through. But usually with these 14s, like you're gonna get it. It's usually like you wouldn't want to use like a 22 on an adult because you're definitely not gonna get through that. You gotta look at the size of your patient. So even on your kids, like if you got somebody under 14, it's a really big person, it might be that you might need to call real quick and say, hey, I got a really big kid. I really don't think this, 18 is going to cut it. Can I go ahead and use this? It's longer. That way I know I'm there. Because once you get it through there, like you don't have to put it all the way down to the hub. You just need to get it through to where you get it into that cavity. And if you have that syringe there, you'll hear that, or you'll hear the airflow come out. And you don't want to keep advancing it on down until you take that needle out. So. All right. Well, thank you guys. Appreciate you taking the time to let us talk to you.
Thank you.
Let's see if I can cut this thing off now.
God bless all of you.